Hello, good morning. I'm Dr. Vijayaraghvan. I'm a senior nuclear medicine consultant at Sri Shankara Cancer Hospital and Research Center, Bangalore. I'm also a fellow of American Society of Nuclear Cardiology. I would like to thank the scientific committee of WCC-ICC for providing me an opportunity to speak on the role of PET and SPECT in heart failure with reduced ejection fraction. So as we know, heart failure has been a major public health problem across the globe. There has been major advancements in medical and surgical treatments. Despite all these, the incidence and the prevalence continues to increase, indicating that there is something more to be done. It's a major public health problem. There is a lot of cost involved in treating patients who survive with heart failure. The role of PET and SPECT is very precise. So, whenever a patient is clinically diagnosed with heart failure, it needs to be differentiated. Either it is ischemic heart failure or a non-ischemic cardiomyopathy causing the heart failure. So, one of the best ways of detecting ischemia is by doing myocardial perfusion scintigraphy. So, by doing this and having a precise selection criteria of patients, for example, a patient who has a heart failure might also have a coexisting coronary artery disease, but that does not be causing the actual heart failure in the patient. So, maybe a patient with significant double vessel disease or LMCA disease with heart failure would be an ischemic cardiomyopathy, and those who do not have such a significant coronary artery disease might still be non-ischemic cardiomyopathy. A precise distinction of this clinical entity is required, and it is best done with myocardial perfusion scintigraphy. Of late, lot of developments, latest advancements in terms of molecular imaging of heart failure. One of the causes of heart to fail is a process called remodeling. Whenever there is an injury to the myocardium, it goes through a sequence of events which leads to hypertrophy, subsequent dilatation, and then heart failure. So, nuclear cardiology has latest radiopharmaceuticals and techniques with which we can actually predict the pathophysiological changes that happen in the myocardium, which can lead to a process of remodeling. We do have tracers that can pick up receptors on the inflammatory cells which carry CXC and CCR motifs. We do have tracers that can actually pick up activated fibroblasts and the consequence of that. So with this, what we can do is we can actually determine those patients who have had a myocardial injury and are at highest likelihood of going into remodeling. So with this, nuclear cardiology, as such, the greatest strength of it is prognostication. So it helps in differentiation of ischemic cardiomyopathy from non-ischemic cardiomyopathy causing the heart failure, particularly in patients who are asymptomatic. We can do molecular imaging to predict those who are likely to go into the phase of remodeling. It also helps in identifying infections in implantable electronic devices in the heart. It can also help in predicting the prognosis of heart failure patients. It helps in selecting patients for cardiac resynchronization therapy and its response to the therapy. We can also do iodine 123 MIBG imaging, which is absolutely essential and in prognosticating patients who are at risk of developing arrhythmogenicity. And the same agent can also be used for selecting patients for cardiac transplantation. Thank you very much.